Welcome to Coffee with Coker, a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry. My name is Mark Reibold, and I'm your host, and I'm a senior vice president here at Coker. This episode is one I think we had a lot of fun putting together, and we wanted to do it as a episode that would go out in early 2019, but it actually comes from a live podcast session that we did in December 2018, where we had a panel at Coker's annual meeting, and joining me was a group of some of Coker's people that represent a cross section of focus areas and areas of expertise. And what we talked about was healthcare trends looking forward to 2019. Basically, what are some of the things we can expect to come and play a role in how things go in the healthcare industry and for organizations in the healthcare industry in 2019. And it actually ended up being a really interesting, intriguing conversation, because with the different areas of specialization and focus that the panelists represent, we got to hear about a couple of different issues, but we got to hear about each of them from different perspectives. And so I thought that was really interesting. I know everyone at our meeting enjoyed it, and so we wanted to make this available as a podcast episode, and I'm sure we'll be talking about a lot of these issues in more detail on future episodes. Joining me on the panel was Brandt Jewell, who specializes in physician services and physician enterprises here at Coker. Chris Torregosa, who specializes in healthcare technology. Stephen Ross, who specializes in financial services and transactions, hospital physician alignment, etc. And Roz Cordini, who is an attorney and a registered nurse, actually, but she focuses on healthcare compliance, and she does a lot of work with hospitals as it relates to compliance programs. And then Aimee Greeter, who's a senior vice president, who focuses on hospital physician alignment as well as strategic planning, particularly for hospitals and medical groups. So again, we had a great representation here. It ended up being a really interesting discussion. I think you all will find it interesting as well. Hope you do. If there's any of the issues we talked about you have feedback on, or if you'd like to hear more information about them, feel free to send us a note. You can actually reach out to us, feedback@cokergroup.com. You can also find us on social media, at Twitter, at Coker Group. You can find us at LinkedIn as well. And then, of course, you can always find this episode, as well as all of our past episodes, you can download directly at coffeewithcoker.com. And so we welcome that feedback, or if you have suggestions for us on any topics that you'd like us to cover in future episodes, we'd love to get that information. But again, we hope your 2019 is starting off well, and we look forward to a successful year, and we look forward to tackling some of these issues in more detail here in the near future. So enjoy, and we'll talk to you on the next episode. We wanted to talk a little bit about, have some topical content, related to what we do and the industry, and particularly where we see things, again, talking about the future, so where we see things going in the healthcare industry in 2019 and beyond. So that's what we're talking about today. But just kicking off, each person, just go down the line, starting with Stephen. Introduce yourself and kind of your area of expertise briefly.
Okay, my name's Stephen Ross. I've been with Coker here 2 years in this role, but working in finance, operations, strategy, health systems, and medical groups.
My name's Chris Torregosa. I like long walks on the beach. I've been with Coker now about almost 13, 14 years. Senior manager with our IT division, and do a lot of our implementations and assessments and such.
Brandt Jewell, Senior Vice President of Physician Services, which means a lot of different things, but typically I'd say we help medical groups and physician practices save money or make money.
Aimee Greeter, I've been with the firm 10 years, and I work with Stephen in our finance operations and strategy group.
Roz Cordini in compliance services.
Great. All right. So as you can see, we got a cross section of expertise and experience and perspective. And again, we're talking about just kind of some of the things on the horizon that we think are relevant to our clients, to the marketplace. And we're out there talking to them and others in the marketplace, what are we seeing? So I know one of the things we've talked a lot about, certainly recently, and I think we're certainly expecting it to continue in 2019. But let's start off talking about value-based healthcare and kind of what that means. And I'm just going to toss this out to the group, so someone feel free to jump in and you guys take it. But we've done a lot already because of our CMO, Dr. Knight, and others who have experience in things that tie to value-based healthcare. But it's still one of those very nebulous, kind of evolving concepts in the industry itself. Any ideas on what you think, or maybe a couple things we can expect for 2019 as it relates to value-based healthcare?
So I think having worked in value-based healthcare prior to joining CwC Group pretty extensively, more on the start of population health management, back when MSSP programs were just starting, ACO was a new word or acronym. We've now arrived at a day where it's no longer innovative. If you're not doing it or you don't have a strategy, you're behind. But everyone doesn't need to have the same strategy. And the real question is, are the economics ever going to work? And they haven't, to date, been largely financially sustainable. You've seen pioneer ACOs pull out. You've seen people pull back on these really significant investments they made back when I was doing that initially, and dedicating millions of dollars to build these networks of providers, all based around quality and cost. And we're going to save costs and drive up quality, and therefore we're going to get more reimbursement for it. And now there are much more ways to get that reimbursement. It's more structured, but you're seeing organizations be more strategic or surgical, even with, we're just going to do bundled payments, or we're just going to do BPCI and co-management with this group, but over here we're going to have a specific contract with a large employer in our market. And so it's less one size fits all, and it's less comprehensive. Alex and I talked yesterday on a podcast with you, Mark, about how they're consolidating value-based care. You don't have to track every metric anymore. Let's focus on the ones that truly are meaningful and the ones that really are tied to dollars at the end of the day. The incentive structure has to get right. And with CMS's recent release on the coding side and things of that nature, I think we're heading in a direction where everyone acknowledges that. But I don't think 2019 is the year, even though MAC has predicted for 8 years running that this is the year, right? that we will finally see the necessary carrot to truly drive change on the physician side.
Yeah, I think a lot of the problem has been, where do you start eating that elephant? And you got to start with a bite somewhere, but even that's been hard to kind of peg. So yeah, go ahead, Aimee.
No, I think that Brandt is right on. I think one of the things that we see a lot of our clients wrestle with is the idea of retooling your operations. How do you impact the bedside, patient actual care to be aligned with the value-based reimbursement or whatever that may be? And I think there's a lack of understanding about what actually changes tomorrow and is different than what I do today to enable me to be of maximal value to my organization. So I understand the strategy. As Brandt said, it's not innovative, it's just course of life, but what does that mean for me, every day in and day out? And so we're seeing a lot of our clients invest in more opportunities for training and education and process mapping, where we're really understanding, what do I do differently? How do I have to change my own behavior? And so I think we're going to see a lot more of that in the year. Maybe it will be the year, maybe it won't be, but I'll take up for Mac to say that I think it can't be the year unless we start to see some of those things changing on the daily interactions with our patients.
Yeah, and I think regardless of whether the change on the physician side actually happens, we started in value-based care by building the entities and putting together the agreements and the networks and the groups. And now we're getting asked to optimize the performance of those groups. And that's been a clear shift from a consulting perspective on what providers and networks need now. They don't need the paperwork anymore. They need somebody to run it.
On the technology side, I think you need to have an EMR system that is able to capture those discrete elements. So it's a workflow change from providers who dictate and from those who do a lot of free text, because that's not discrete elements that provide the analytics, obviously, for value-based healthcare. So we had a client trying to do value-based healthcare, so they picked Athena Health. And one of the things is we wanted to make sure when they went live was the providers understood that there's no more dictation, there's no more free texting, everything is point and click because it provides us with those elements that we need to report. So having the analytical tool in the background to obviously provide to the payers is the other step in terms of trying to truly do value-based healthcare.
And that's how you monetize it, because that's what the payers are ultimately going to be able to
Exactly.
track and
They want that
change
data.
reimbursement based on.
And I'd just add to I agree with the comments here of my colleagues, but I would also add that I think it's at some point going to be very important to be able to prove to the patients that you are genuinely achieving the goals of value-based care in terms of bending that cost curve. I know today, and just recent studies have come out that, again, as Brandt mentioned, the financial, economic elements there, the cost curve really hasn't bent that, per projections. And a lot of these board members, they run into their church members and et cetera in the grocery stores and at soccer games and et cetera, and they're asking, why is it so expensive? And I think being able to help effectuate that, these activities will actually achieve the stated goals. That's still something that, as an industry, we haven't quite quantified and achieved yet, but we've got to go down the direction.
Yeah.
I think the patient perspective is, again, an interesting one, and Stephen, you've alluded to it, but people care what their experience is like as a patient. And so to Chris's point, if it's taking the provider twice as long to see the same number of patients, or if I have to wait an extra 40 minutes to be seen because my provider is moving slow, we have to do some retooling of operations, some expectation setting on the patients. Maybe it's just communication about, hey, we're doing something new and different here. It's going to be great for you in the long run, but we need you to bear with us a little bit now. That's the why question. We talked a little bit earlier today about starting with the why. And so if patients can understand why things are happening and changes are occurring, they're going to be more want to buy into them. So I think, again, keeping that patient first and foremost is an excellent perspective.
And I can jump in from a compliance perspective. As Chris mentioned, without discrete fields in your EMR, your outcomes that you're reporting are left up to the individual who happens to be in the record or not in the record collecting that data. And so it can become an issue if you're submitting data that's inaccurate and you're audited, and now all of a sudden you owe some money back to CMS. And also organizations who employ providers struggle with how to incentivize their physicians using that data, because some of those measures, you have an ancillary staff person who is providing that part of the service or entering that data, and you really are prohibited from paying the physician at that point for a service that's not personally performed. And so organizations just continue to deal with those difficulties.
Yeah, so that actually, I guess the point is you can't take on more risk if you're not prepared and equipped to appropriately manage it and ultimately be able to monetize it. And so Roz, maybe continue on that thought a little bit and tie it back to kind of broader compliance issues, broader compliance things that particularly hospitals, health systems, and medical groups as well really need to be thinking about going into 2019 and some of the things that may be on the radar here for the next couple of years as it relates to compliance.
In general?
Yes, yeah, sure.
Well, compliance in general, always compensating physicians is at the top of the list, whether it's your employed providers, whether or not you really have a solid fair market value, commercial reasonableness opinion in your file. That's probably the highest risk. There's an awful lot of continued OIG fraud alerts and lots of settlements out there of billing issues that organizations have. So essentially, without a really solid risk assessment that's performed annually, and putting together an effective work plan that you're actually operationalizing and doing those audits and putting corrective action in place and re-auditing and educating and on and on and on, organizations can continue to find themselves under scrutiny with the governmental payers.
Yeah. Yeah, I'll just add too, Roz, I agree with your comments wholeheartedly. I think it's getting more and more important for both health systems and medical groups for the leadership, whether that be administrative leadership or the boards, to really be educated on what these key compliance concerns, the why around that are, so that they can, not just give lip service as a box to check, but truly in carrying that flag for the organization, get everyone on board, or else, long term, these issues are going to continue to crop up. Sure.
And the other issue from a compliance standpoint that's going to be in the forefront for, as far as I can see ahead, is the HIPAA security issues. And that's just going to be more fundamental that organizations focus on, especially with all of the health information exchanges that are out there, and we're sharing more and more data across different platforms, if that's the correct IT word, but we need to be much more aware of all of those issues.
Let's talk about that. Circle back to you, Chris, if you don't mind. You can kind of lead us off here, but I want to talk more about the technology component here and some of the things we're going to anticipate for 2019. And I know one of the things we've done a lot is, other than kind of your standard implementation and project management type stuff, but on the security side, and that goes hand in hand with talking about the importance of data, obviously. Yep. So maybe comment on that and any things clients need to keep in mind there.
Yeah, we're staying at a Marriott, right? So last week they got hacked and 500 million of their users' data, credentials all were released. When it comes to healthcare, of course, patients value that their sensitive information, their medical history is secure. It's guarded. Obviously, no one has access to it for HIPAA reasons. And in this day and age, with all the HIE exchanges, there's tons of points of entry where that information could be hacked. So, obviously, a lot of organizations that's paramount to them to make sure that they get their auditing, their system is verified and secured and meets HIPAA compliance standards. Shameless plug on CwC, we do some of that stuff too. Marissa and Carlos, obviously. And I think we even helped a client who got some ransomware and helped them kind of lock that down. But from a security standpoint, a lot of it kind of starts at the ground level, having policies and procedures in place for your staff to let them know that if we saw a video on it, if you get a text message, if you get an email, don't click on it if it looks suspicious to you. Report it to your IT group so that they can flag it and make sure everyone's quite aware. So I think it kind of stems from there, but at the same time, I know a lot of organizations reach out to independent experts as well to help with satisfying some of that cybersecurity stuff.
In terms of data, and Brandt, you referenced this, and I know I've heard you talk about it before, but if these things are going to work, some of these operational improvements and performance improvements, particularly in a value-based realm, maybe just speak more to that in terms of the importance of data and kind of what organizations can be thinking about to get ahead of that curve, because we know, again, the preparedness is all over the board, I'd say, in terms of how ready they are for these types of things.
Yeah, I think on a value-based side and on a reimbursement side, the data is king because that's how we're going to measure progress and ultimately get paid for any progress in those areas. A lot of the groups we work with are what we call it data-rich, information poor. So yeah, we can find all the things that we want now. That used to be a struggle, right? Just getting the data. Now it all exists, but everyone owns their own different spreadsheet, or you run a manual report out of this EHR, but then your billing report comes from here, and you can't match that to payroll because the departments are coded differently. Things like that are really in the nitty-gritty weeds of operations, but significant size health systems struggle to put all that in a meaningful format where they can then make decisions based on that. And so a lot of our engagements when we get in and implement improvement center around establishing a baseline of consistent data and metrics that can clarify from your C-suite to your frontline call center reps what the expectation is, what the goal is, and then be clear with them about how they impact the outcome of that number. How do I impact no-show rates, or how do you impact our revenue stream? And so I think increasingly we saw a tech boom where everyone acquired and purchased software from dozens and dozens of vendors, and now people are trying to consolidate that, which Chris helps them do, I think, regularly. And the struggle to use the information we have, I think, is the next IT step or data step that a lot of systems really haven't taken yet, and some of the bigger ones who have the systems struggle still to make meaningful change with it.
Yeah. I mean, I think it's safe to say the challenge of just getting the information is big enough, but then making it meaningful is something that's a totally different issue, I guess. Changing gears a little bit, I recently learned, and Aimee, I'll let you start with this if you don't mind, but I recently learned that I think as of 2018, it was the first full year where healthcare was the largest employer, the industry that was the largest employer in the country for the first time, first full year. Why is that meaningful? And maybe just speak to that impact in the future for that particular point.
Absolutely. So we are in a very seismic change at the end of 2017, and for the duration thus far of 2018, we had a shift from manufacturing to healthcare as the largest employer within the United States. And that's huge because America as a country has really been founded in manufacturing. And so our complexion as a nation is changing into how we support our able-bodied workers. So it's an exciting time for us. It's a great industry to be in. So if anyone ever questioned whether healthcare was good to be in or not, the answer is proving out to be yes, it's a good field to be in. But it's important because we're thinking about what does this mean in terms of the jobs that are being created or need to be filled. So 5 out of the 10 fastest growing jobs that need to be filled are in healthcare, and they relate primarily to patient or elderly care. And so as we think about utilization within health systems, we need to be thinking about how are we going to provide support as our nation gets older and as there's more demand for those services. And there's going to be a need for more jobs to be filled by people who can perform those roles. And you have to think naturally about, is there going to be a competitive environment where it'll be difficult to get people to fulfill those roles? Those roles are not going to be heavily clinical. The data indicates that it's really going to be operational or administrative roles that need to be fulfilled to finish those services or complete those services. So if you've ever had a parent who said, why didn't you become a doctor? You can tell them that, you were just forced, you just had a lot of foresight. So being a doctor isn't the place to be. It's really in those administrative or operational roles going forward. So as we talk with our health systems about that change in our overall employment structure, and we think about what does that mean for us in healthcare, to Mark's question, it has to be part of our overall strategic plans. Workforce is constantly an element of discussion in our strategic plans, but it needs to be more so now as the complexion changes. How are we going to recruit top talent? How are we going to retain those people? What do we need to pay them to be in those roles? And then how do we as an organization have appropriate supports so that those staff can provide for our patients and our elderly as the needs are the greatest to really be the people that we need to be.
Yeah. Well, I think it's interesting too because the skill sets or the diversity in skill set that is being seen more and more across the workforce in the healthcare industry is I think another telling thing about how the degree of complexity the industry entails too. So I mean, you go into any health systems IT department, IT, IS, whatever, and the range of knowledge those people have to have, and it's not just technology either. It's not just very technical in nature. It has to connect and intertwine with the business practices and the strategic plan, those types of things. Same thing on anything, Roz, I'm sure you're involved in looking at things from a compliance standpoint. There are so many different angles. Like you said, compliance one day could be talking about fair market value issues, but you also got to understand the business case for why you're aligning with the physician in the first place. And so, there are so many different elements that I think, just adding layers of complexity, it seems. Maybe talk to that, Stephen, if you can, in terms of a little bit of the perspective on the alignment trends going forward, because we've come out of, or we're still continuing to work through a lot of consolidation, but specifically on the hospital physician alignment. I know you've seen that from both sides, the hospital side, but from in terms of what we do, what are your thoughts on that in 2019?
Yeah, it's a great question. I don't think I would be the first to say that the healthcare industry is cyclical. Back in the 90s, a big consolidation phase, and then kind of walked away from that, and then back in the 2000s and continuing into the early 2010 and so forth, another consolidation stage. And interestingly enough, we've had a few examples in our recent last few weeks of health systems saying, hey, we're really rethinking this whole, let's just employ physicians as the best way to achieve alignment or integration, and now they're starting to think about some creative alternatives, whether that be participation with other ASC opportunities, or instead of just going down an employment path, we really need to focus on maybe PSA type arrangements, but maybe not something traditionally structured where we're just going to look at survey data and kind of come up with a comp arrangement or a value arrangement, but really looking at, okay, the local market is the basis for defining the economics. And so we were just, let's set aside national data that may show higher levels of compensation or revenue is appropriate, and let's just really focus on what value are you providing to your local patients, and how can we use that arrangement to provide better overall care to our community. So that's kind of an interesting, I don't know if that's a blip or if that's going to be a trend. I think it's going to be more of a trend as we head in, is a lot of these organizations are saying, hey, now that I've got it, I'm not sure if I can afford it long term. How do we make it affordable?
I think one of the things that we see too, and if you've ever seen me speak at a national conference or read any of my white papers, you know that I am completely enamored with dating analogies, so I cannot let you out of this room without giving you one of my dating analogies. But I think that we have seen a lot of marriages, as Stephen referred to, a lot of integration between health systems and physicians. And we're now at that pivotal time where some of our friends are starting to get divorced, and we're starting to see an opportunity for disengagement. And so it's either physician practices that think they can do it better themselves, independent of an employer through a health system, or health systems who have said, you spend a lot at Macy's and we need to, separate ourselves from this relationship. And so health systems are looking at disengaging and having the opportunity to use more of their resources in a different way, as opposed to supporting a physician network. And so as that unfolds, I think there is an opportunity for innovation. If you're going to restart, whether you're going to start fresh or, you're going to start lighter, in essence, without those physicians, I think you have a bit of nimbleness where you can really think about what do you want to be. And it provides this great opportunity to think out of the box, to be innovative. So for me, I think it's not necessarily bad that we're starting to see some of this change from, build it, let's get bigger and better, to let's become a little bit more nimble. I think there's a lot of opportunities that can be affordable. When we think about the value-based environment, it's not necessarily that the biggest groups are going to be the most successful. It's often that those that can be the most nimble will be the most successful. So I think it will be interesting to see what can a smaller, lighter set of physicians or a smaller, lighter physician enterprise do. Maybe it's something great. I guess we'll see.
I think the size of the organization and the circumstances also really dictate the financial motivation to employ, not employ, partner. Hospitals are increasingly concerned that physicians don't need them as much as they used to, right? We can do all this outside the walls and make our own money. We can be independent, and hospitals don't want to become the brick and mortar dinosaur, Blockbuster. But on the other side of the fence, hospitals are increasingly interested in building a network that they can have to drive the revenue. So they want more physician alignment, but they're less and less capable and or willing to just employ every doctor that comes knocking. But you're seeing these massive health systems emerge, and then really small independent health systems maintain their independence. It's the ones in the middle that have to make a choice, right? Do we find a partner? Do we let ourselves get acquired? If so, what are we worth? How do we determine who to partner with? Or can we go it alone? And there's just a lot of fear and uncertainty on both sides of the fence, and we haven't figured out what, as we've gone through these cycles before, we have never figured out what the ultimate future will hold in terms of physician-hospital alignment. But with the trend of value-based care, it's safe to say that we are moving away from hospitals as the gatekeeper to all healthcare. We've already moved away from it. And so the onus is going to be on hospitals, which has traditionally been the bank as perceived by the physicians, to adapt and change and make themselves relevant and meaningful partners to the physicians moving forward, and not just a bailout strategy.
And I'd just add, great points there, Brandt. But as we have this younger group, I would say, of hospital administrators, health system administrators, I think that that innovation will really spark as maybe the older vanguard is retiring now, and not from a derogatory sense, but just I think a new age also will bring fresh ideas, and so I anticipate seeing a lot more innovation along those lines.
Well, I think you can't be nimble without the tools that allow you to be that foster that innovation, and thus do things with more scalability and more efficiency and some of those things that perhaps the healthcare industry has been a little bit slow to adopt at times. Do you think, Brandt, to your point, that if the hospitals are no longer the sole gatekeepers, if you will, does that create a more competitive attitude between hospitals and physicians, or because we did, Stephen, you referenced it earlier, what we saw in the 90s, and there was some fallout kind of in the way that dynamic evolved, or are we really fostering hey, we can all partner in this thing together? There are different ways to do that. We don't have to be one against the other. Does that make sense?
I do think that everyone says the right things in that regard. We all want to work together, and neither the payer, the hospital, or the provider can stand alone and make it. This whole idea of population health and value-based care is there's always been a pie chart for the healthcare dollar, and no one wants to give up any piece of their pie so that the greater good will be delivered. So what do? We make the pie bigger, and by doing that, we reduce the cost of care and how much cost there is associated with all those entities providing care to a population, and then therefore there's more money to share in that pie. So I think it's a bit of a check and balance where the hospitals can't just run away and say, forget you doctors, we don't need you anymore. The insurers can't do it either. But you're seeing some organizations, take Optum for instance, based on the Kaiser model, right? Mm-hmm. And we're going to be all three, and then we control our entire dollar. We pay ourselves, we provide the care ourselves, we build our own facilities. And now they're doubling down on that strategy, more doctors, bigger networks, more comprehensive, and ultimately those costs will break them if they're not successful in reducing the cost of care. So everyone's, even in this fee-for-service world that we still live in, there is a very obvious play here of we're going to double down on this strategy because we believe there's a shift. And I think we're seeing that now from CMS, well, not just now, but it's coming to fruition that's the strategy, and you're seeing non-CMS entities pursue it the same way. So I think there'll be collaboration, but everyone still wants a bigger piece of that dollar.
You think we'll see more of that model, the Optum that you referenced model, where they want to try to be payer, provider, and really kind of dominate the dollar flow?
Yeah, I do, but it's hard to do. I mean, Kaiser has even struggled knowing how to do it. They've struggled significantly to replicate it in other markets outside of California, really, as their stronghold. And so it's not easy to convince all the doctors in the entire market to work for the same health system, or for all the hospitals to partner with the same payers. And it's expensive, so only a few organizations can pull that off. So I think if I could make an analogy to the commercial industry, where we're going to have massive stores like Costco and Walmart continue to be successful, and then we're going to see a lot of boutiques continue to thrive. This idea of Small Business Saturday and all that kind of stuff. It's the Bed Bath & Beyonds and O'Charlie's of the world that are going to lose out at the end of the day, because no one wants that half and half anymore. So I could be wrong about that, but that's my speculation on it.
Don't worry, I need a new set of towels, so I'll keep that Bed Bath & Beyond, in business for a while.
I'll try to change that to a marriage analogy.
Use a dating analogy next time, please, Brandt.
So I will say
all dating analogies.
There is a British economist that I like, and I always, whenever I read the quote or think about it in my brain, I always put a British accent on it, so I won't effectuate that for y'all's benefit today, but you can think about it. And he was talking specifically about bundled payments, but I think we can extrapolate it for a lot of different going concerns within the healthcare industry. But he said the distribution of dollars that come in, again, under bundled payments, and how it flows outward will be reminiscent of the last scene in Braveheart, with everyone fighting to the death for their very last cent. And I think that's exactly what we have to think about, is either we're going to fight each other to capitalize on the pool that's available, or we have to think about expanding the pool to be bigger so that we're not infighting with somebody else. We're growing our own pool organically or through mergers or however that's going to happen. So I think we're going to continue to see people wrestle with, do I fight for the pool that's available, or do I have a bigger dream?
Yeah, so I'm going to come back to something. Stephen alluded to this, and Roz, I'm going to direct this at you because I want you to put your, attorney, legal counsel, compliance officer hat on for a second. And but Stephen mentioned or kind of alluded to the need to continue to explore various types of arrangements and structures in a kind of a different way than the conventional way or the way we've historically looked at things like market data, benchmarks, things like that. So I guess, but generally speaking, do you think we are getting, as a system, as an industry, are getting more flexible and innovative in terms of how we can look at some of these arrangements? And so, they're not all hospital physician arrangements. There's a lot of different kinds of things out there, but I guess specifically to that, from a compliance standpoint, or are we still really concerned about the pressure from the OIG and what's going to happen from what risk or how much exposure do we have there? Does that make sense?
Yes. So first thing is the disclaimer. This is not legal advice. I'm kidding.
Yes.
No, I think there's been a lot of talk, and CMS put out a request for comments on the Stark Law and trying to make some changes that would be helpful. But they've not done it yet. And really, as much as everybody hates the Stark Law and how cumbersome it is, as long as it's here, it just has to be dealt with. And so those concerns really have not gone away. I think what health systems are facing is the loss per doctor they're experiencing. And looking at some of the survey data out there, and they say, okay, well, we're about in line with what the average loss per doctor is, but you still have some of the case law out there, Stark Law, cases where the government's position is it does not make any business sense to lose money on somebody you're hiring. And obviously there's a lot more factors that go into that, which is what Randy's job is, to articulate all of that in his opinions. But, so that those issues aren't going to go away. But I do think organizations have to be more strategic in who they're going to partner with. Everybody employed everybody, and really looking at who's providing value to our system, operational value. Who do we really need? What kind of specialties do we really need in our service area? And going after some type of alignment, helping them get back into practice in the community and support your hospital, but figure out some type of arrangement to keep connected with the health system. But like everything else, trying to be more innovative and disruptive in how you do it, because I think everything is cyclical and we tend to do things the same way over and over and over in different decades. And, we have to be more creative to sustain.
One of the things I know, I wrote a article on this recently, and we've done some work around these types of scenarios, but the idea of hospitals competing on the alignment side, specifically new participants that are in the market, and then even more specifically, you have private equity investors or consortiums, platforms that are private equity backed, and they're able to write big checks, and they're able to really quickly disrupt a market. And of course, every healthcare market, it truly is local. I think that's one of the last truly local marketplaces. And so, I'm curious if that's going to be something from a transaction standpoint that we can expect to see more of. A lot of investors want to be in the healthcare space, and they said in the past, well, maybe owning a hospital isn't the best idea, but this group of doctors poses a lot of value, and if we can work out a structure or an arrangement that everybody can kind of win, seems like doctors are a little bit more open to that. Have you guys seen the same thing, or any observations there?
I think it'll be interesting to see the financial world and investors who haven't traditionally been healthcare players try to realize value on those investments. They're not investing because they like owning hospitals or physician groups. Sure. It's not HCA buying facilities and then trying to optimize them. It's people trying to get a return on a dollar.
Yeah.
And as we've seen over and over again, you buy a practice, put it inside your health system, and all of a sudden it doesn't look like the same investment that it did when you were analyzing it outside your own walls for a variety of reasons. So time will tell, but I could see this being a cyclical thing where a lot of money pumps in, returns don't meet the initial projections, and then you have a divestiture of assets in the same way, which could really end up being a bad thing for physicians and for patients when they're no longer when the physicians are no longer sought after as as these investments and the dollars aren't flowing to them. Now they're not able to provide care in the communities that they initially did, and I could see that spiraling downward. So I don't particularly like what I don't want to call it unintelligent money, but just non-healthcare investments coming into the market, because I think it could pollute it, and there's also not the same incentive to preserve the quality of care for the patients at the end of the day. If someone from an investment bank in Manhattan owns a practice in Topeka, Kansas, they don't care if they need to sell it and cut bait.
Yeah, I think it's interesting. In speaking with my friends in private equity, I've always heard that 5 to 6 years is the ultimate time in which they need to have made a return and then catapult the business onto something else. And so what I see is 5 to 6 years, while that's a good amount of time in healthcare, can actually be a pretty short amount of time. We, I think, as an industry, tend to move a little bit slower than other things like technology or other industries. And so I'm wondering what happens if the 5 to 6 years, the return isn't there. And I think to Brandt's point then, if there is that divestiture, the people in Topeka are going to be hurting because they're going to have a physician group that's going to have to decide to either leave the community, pursue an alternate source of capital infusion, or align with another entity, and that may or may not yield the greatest results. So I think that 5 to 6 year time frame that private equity often targets is tricky in our industry.
Well, and sometimes those big dollar signs that they see on the front end of that deal obviously are very attractive. There's a lot of appeal there, particularly for maybe a physician that's been in practice a long time, is on kind of the tail end of their career. It's a great retirement option, but there are some things maybe they can come in and do. Maybe they can implement more efficiencies and technologies and do what in theory makes an organization run more efficiently, but still leave a lot for exposure in that local community, on the community need, on the kind of the trickle down effect. How does that affect the access in that market? Again, maybe they have to leave the market entirely or something happens.
And you think about, we talked about this distribution of dollars being somewhat difficult. If you think about the fact that you're going to give some of your top off to private equity right off the bat, and you still need to pay your bills, how much of the dollars are left for feeding the philanthropic interests of your community, the 5K runs that you had traditionally supported, et cetera? Unless private equity sees that as a marketing opportunity that can have some return, I don't know that there's the inclination from heavy business people to fill those philanthropic needs. And again, these are our communities that we're talking about. These are our people that we're talking about. So it's not necessarily, I think, always compatible for big business and healthcare to be having aligned interests.
Yeah. And I'd just add to that, I think the best defense against that kind of healthcare moving out from local control is whether it be a health system or a medical group that is very in tune with the needs of their patients locally and are proactive to provide those needs. I mean, in several health systems we work with, those that have really understood their demographics and what they're looking for, whether that be adapting an urgent care type strategy that they need, as opposed to a medical home type strategy in certain cases, that's a good defensive barrier at times, but it's going to be different for every location, I think. And being really in tune with the patient's need is first and foremost, especially if they can meet that need and demonstrate that. I think that won't be an attractive market.
Yeah, that's a really good point, because I think the bottom line there is that I think sometimes it seems, maybe just everyone accepts this on the surface, that, okay, private equity or whomever, big dollars are coming in, the big players, they got big checkbooks they can write, and it it's kind of impossible to compete with them. But I think what's been interesting to see in multiple cases now, we've seen multiple groups that were down the road doing transactions with private equity or private equity-backed for-profit entities that just assumed there was no way they could do a deal with the local hospital. They just couldn't pay the kind of dollars. But those hospitals that have stepped up and said, hey, we can be innovative here, we can be flexible and still be within the bounds of compliance. And do it right, but do it well. And then there is truly not only benefit there for the hospital and then the system, as well as the physicians, But the community impact, actually, I think they've seen as a result, is significantly greater. I mean, everyone I've seen, there's been significant growth following those initial transactions. In terms of, I want to talk for a second about kind of financial strategies and financial growth. And Brandt, maybe you can kick us off. And I really want to dive into performance improvement, because I think as we've gone through some waves of consolidation, now we've embraced perhaps the loss per physician ratio, to a certain extent, and at least can try to come to terms with that. What do we think about now, or what can we look at for the future in terms of, okay, how do we go and really optimize and do something, create value from these deals?
Yeah, I think we talked a lot about financial motivation for change, and recent cases for us again are C-suites that used to say, yeah, I'd like to lose less, or I'd like to see a smaller red number attached to my employed physician network, are now saying, if I don't see a defined dollar amount decrease in our losses, then we have to close our hospital down, right? Like now we can't afford to stay in business for more than X number of months. And a lot of people have kind of figured that math out, and that's a burning platform that we haven't always had on the performance improvement side. And the problem, I think, when you talk about performance improvement is a lot of the levers you pull to improve performance don't necessarily tie directly to dollars. It's not always lopping off a site or a location or a service line or whatever it is. And a lot of times the best way to improve performance is top line growth as opposed to expense reduction, which kind of flies in the face of traditional hospital management again. So it's a process, and it's not easy, and you have unwilling participants, because a lot of the doctors that you're relying on for the performance to improve don't necessarily have the same economic interest. And so the alignment of incentives between the health system as the employer and the providers and having skin in the game is probably one of the core components that is missing in a lot of places, and only in certain circumstances that, like a client we're working with now, where everyone just wants to maintain independence. We have a common goal, and I as a doctor am willing to play that game to achieve the goal with you, my employer, so that I don't end up also working for Optum or Kaiser or whoever else is going to come in and buy us and tell me what to do. So performance improvement isn't easy. Some people approach it surgically and say we've got to get better at rev cycle only, or we know we have a staffing issue, or we have a compensation issue, and we just want to address them individually. But really, our approach and recommendation tends to be, let's look at everything. If we need to be surgical, we can. And then ideally, we comprehensively address your employed provider network and your employed provider strategy, alignment strategy, so that everything works in concert. Because if you just start pulling individual levers, which we've done for a long time now as an industry, you're not going to see enough improvement in a time frame that will get you the results you need, in some cases, to keep the doors open or to stay independent or whatever your goal is.
Sure. Do you think any, going back a little bit to the alignment discussion, but something you said kind of reminded me of that, but the idea of Aimee, actually you alluded to it earlier, divorces. Do we think there's going to be more kind of reversals going back private? Or is that a growing trend? Is that a one-off thing? Is it market dependent, that type of thing?
Yeah, well, I think it's always market dependent. So it's, as we said, healthcare is impacted by what happens in your community. So I definitely think it's locally driven. But I do see, as the belts have to tighten, there's some excess that comes out. And I can see that these disengagements, as they have continued to increase, will continue in that trend. They're going to have to look at some other place to be if they can't be in their original construction. And so while I don't think it's always advantageous to the health system, to the physicians, to patients, it's massively disruptive, as you can imagine. If you have to call and set up yourself with a new provider, even though it's the same physician, they have to go through all the re-credentialing process. They have to be backfilled in most cases, because most health systems can't afford to just have an exodus. They have to backfill it. So it's massively disruptive. I don't encourage it as a strategy, and for most of our clients it doesn't make sense. However, there are occasions when it does, and I think bringing that to awareness is helpful, to just think about it as a strategy that warrants consideration. Again, it's not for everyone, but I think it's worth considering.
Chris, maybe you can speak to this. Let's say a sizable group is leaving a hospital affiliation, and they want to kind of go either back private or maybe go private for the first time even. I can't imagine the infrastructure and business process, but the starting from scratch just on the technology piece alone. Maybe speak to some of those things that come up in that process.
Actually, we had a project like that this year. It's a monumental task, especially when you don't get any demographics, any clinical data. So everything literally starts from scratch. Your EMR system's blank, clean canvas. Setting up the offices, making sure workflows are trained, making sure all your applications are integrated with each other, everything from your practice management system to your EMR to your interfaces with the hospital, because you're still going to use the hospital for labs or any of the imaging centers nearby. We had a client where this took us a good 6-7 months to literally get them up and running, and almost 60-70 hours a week, just basically getting the system set up. And I can't tell you, it's when you don't have the data and you have to call your patients and say, hey, your provider has left X hospital and is now joining their own network. We need to kind of capture all your demographics from scratch. Otherwise, we can't really register you in the system. And you can't just tell patients like, oh, we're going to be open at 8 o'clock tomorrow, go to this office and stand in line and we'll go ahead and register. We were creative in ways that we were able to leverage our patient portal so that they could register themselves, and then the demographics flow into the EMR system. But even from that standpoint, we didn't want to open the floodgates where they can go ahead and schedule their own appointments, because there may be certain circumstances where they're a brand new patient, we don't have their clinical data, so we don't want to put them in this time frame or see this particular doctor. So we had to set up a call center just to reach out to these patients who did get registered in the system. And for a period of time, we had to obviously implement this and structure this appropriately so that it sequenced with the go lives of our locations. And at the same time, if you're starting from scratch, not all your offices will be up and running in one date. So you're relying on construction, relying on getting your TCOs and make sure everything is inspected and registered. So I can tell you we're not even done yet, and the go lives are still going, but it takes a true team effort to get that type of work done, for sure.
And I'll brag on Chris because I know he won't, but Chris and another one of our colleagues, Tina, supported by a host of people, Jeffrey and Steve and Denise and Lynn and a number of people. Not only did they have 6 to 7 months of really working at this, they had a good amount of time just planning it. Even the planning time that goes into this process is extensive. And so we had a great team who made that happen with a successful outcome for our client, and they have a lot to be proud of there. But I will say it just takes a lot of energy, even when you're not on the ground. Before you even get to that stage, there's a lot of thinking time that has to be built in.
Yeah, to your question about if it'll accelerate, it'll be hard to, because I think that's a not survivable event for a lot of organizations.
Right.
Doctors always think that they could go back to private practice and do well again like they did the first time. But there's a reason that doctors are approaching hospitals locally every day saying, hey, if you don't employ me, I'm leaving the market. And so the idea is nice, but the work alone would stop a lot of organizations from taking it on. And then I really question the sustainability. It's hard enough to just maintain independence these days as a practice, but to go through an event like that and basically start over and all the costs and time associated with it, I think there'll be some attempts, but I think we'll be interested to see how successful they are and if people can replicate.
Well, not to mention the capital that's needed. I mean, that's a non-starter if you don't have that. And then, all right. Well, this has been great, and I want to bring it back full circle. So to kind of wrap up, I'd love to just go around the horn. You guys, maybe each of you talk about what you think is either kind of the biggest thing you predict we can look for or expect for 2019. Or maybe some interesting opportunities coming down the pipe here in the next few years, maybe.
Yeah, I'll go ahead and start. So, I really think that the whole focus on value-based care is kind of here to stay. I'm not sure what form that'll take, but with CMS's recent announcement that 55% of hospitals will receive some type of bump in value-based payments, well, the inverse is true too. 45% won't. We're seeing it in our arrangements that we are involved with, that quality outcomes But at some level, we've got to bend that cost curve, or else it's not going to be sustainable long term. And I think there's going to be a continued focus on that piece of it.
Chris? From a technology perspective, I think you're going to see a lot of healthcare systems and employee networks and such, and medical groups start kind of rethinking their technology in terms of, I hate to say this, but leveraging your cell phones, leveraging the patient portal. There's certain software now where I can check in for my appointment ahead of time. I can also see what my wait time is for my provider. And then there are tracking boards where it doesn't list your name specifically, but it assigns you to a patient ID, and it'll tell you where you are in the process of the EMR system, whether your forms have been filled out, whether you are ready to be taken back to the room to do your intake vitals. And then obviously the patient care summary that comes out, you can start leveraging and seeing your lab results on your own phone. You can go ahead and schedule follow-up appointments from your phone. So those type of things, I think, as technology is evolving and as people, are getting more comfortable with technology, I think you're going to start seeing that more prominently. And you see that right now with the bigger healthcare systems, but I think you'll start seeing that really in the private practices and all those employee networks as well.
Yeah, I agree with both of those. And value-based care, I think, will continue to impact all decision-making because it's essentially proven that it's in some form or another, we got to reduce the cost for improved quality and get people healthier. I think in 2019 in particular, this fury and of activity around acquisition has challenged everyone to say either what are we worth if we want to get acquired, what's it going to take for us to stay independent, and if we do want to get acquired, how do we make ourselves as valuable as possible? If we're doing the acquiring, how do we value that? And so I think on the valuation side, everyone's questioning their worth, or they want to know what they're worth, and then they want to know what they can do to improve that as they go. So I think both for performance improvement, alignment strategy, and then the transactional side, I expect 2019 to be a pretty active year on all those fronts. Yeah.
So I'm putting my money on the little guy. In 2019, I'm going to throw all my support to urgent cares. Okay, I think that they're fascinating as a site of service to see the expansive clinical care that can be provided in an urgent care. I think it's wonderful as a low-cost solution that, again, speaks to the value-based environment that we've been talking about here. I think that they can be repurposed in a number of ways. If you've ever gotten your flu shot at a Walgreens and been in that little box, there's so much that you could do in that tiny, tiny space from a clinical perspective. So I'm betting on urgent cares. This is going to be the breakout year for urgent care.
I think that health systems and hospitals are going to continue to evaluate their costs associated with providing care overall. And I do think there's going to be a focus on strategically maintaining an employed physician group of who's actually needed. And I do think we'll see some breakups that are not necessarily negative breakups, but breakups that may be good for the community and for the physician to go back into private practice, notwithstanding all of the technological and other issues. So I do think we're going to see more focus on some of those other alignment models for health systems. From a compliance standpoint, I think we're going to continue to see a focus from the government on how healthcare organizations are paying physicians. We keep seeing key TAM relators, so whistleblowers are, turning health systems and hospitals in for how much and how they're paying physicians. Allegations, of course, are not necessarily validated, but there's a lot of scrutiny, and I think that's going to continue so long as we have the same legal structure that we have.
Yeah. That's great. Well, thank you guys for your input. Let's give them a hand. Thank you. We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main CwC website at CwCgroup.com. You can also find us on social media, Twitter at CwC Group, and then on LinkedIn, you can search for CwC Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@CwCgroup.com. That's feedback@CwCgroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.